enjoying lovely Vienna and the ball from last night. So I'll be talking a little bit about combining ECP with minimally invasive glaucoma surgery and some of the work that I've been doing in this field. These are my disclosures. So let's start with what most people know about ECP already. The first minimally invasive glaucoma surgery, it has been used for several years before the advent of trabecular bypass and devices in the trabecular mesh. It can be performed as a standalone surgery in phakic and in pseudophakic and aphakic patients. And it reduces the IOP by reducing the aqueous production. So again, that's where it has quite a unique space in the MIGS field, because most of the products are geared at improving the outflow, whereas this is geared towards reducing aqueous production. So a little bit of anatomy here. You have the ciliary processes, which is the treatment area for ECP laser. And specifically, you're applying a diode laser to the ciliary process, which is absorbed by the melanin within the ciliary process. The actual technology is very good. It comes in a machine which is very easy in the OR to bring in and bring out, depending on cases. But essentially, you have a 810 nanometer diode laser with a 640 nanometer aiming beam, high resolution video imaging, and a xenon light source. One thing to be aware of is the cable that it comes in is fiber optic, so it's very important to handle it with care, because that's how the image is transferred. So you must not bend it, otherwise you can damage the probe, which can be used several times, particularly if handled carefully. So when you're combining ECP with cataract surgery, which is probably the most common use in the US and worldwide, what I do is I perform my cataract surgery as I normally would do. Once I implant the IOL in the bag, I remove the viscoelastic from the bag and then inflate the sulcus space. It's very important to remove the viscoelastic from the bag because you need to give yourself a good space when you do the ECP, otherwise you run the risk of damaging the capsule, damaging the zonules, or rubbing against the underside of the iris, which has a lot of pigment. So giving yourself that sulcus space is important. And the actual technique itself is using low energy, so 250 milliwatts. If you compare that to transscleral cyclodiode, it's a sixth or an eighth of the energy that you're using. So it's very much a low energy diode laser. The word diode has a bit of a connotation or a stigma that this is aggressive, it's ablation, it's destroying. But really, when it's targeted, what you are doing is a very targeted, gentle ablation. And here again, it's very titratable. So you often don't have to change the power. You can achieve the reaction that you want by either moving slightly closer to get a bit more of a reaction, or if someone has a lot of pigment in their ciliary processes, moving slightly back. But as a general view, when I'm training my fellows, you sort of say you want to see 3 to 6 processes at a time, and then according to the reaction, which you can see very clearly in that top right schematic, you can, from that reaction, you can see if you need to move further or closer. You want to treat from the tip all the way to the top, very much like Kid and Mr. Miyagi teaching Daniel-san. You wax on, wax off. You want to make sure you go too high and treat the side of the iris. And you're wanting to see that whitening and shrinking, and it's very important just to take the time to allow for that full process. And as you said, you want to avoid the underside of the iris. And really, you know, the jury's out about how much to treat. I treat 360. I looked at data, the amount of extra that I was getting from 270 versus 360, I really wasn't getting much more. And that saves me having to do an opposite clear corneal incision, which adds an extra incision to your cataract surgery, and ergonomically is not the most. Whereas particularly with the curved probe, going through your main incision and your side port, you really can get round to 240 to 270. Post-op regimen, again, like cataract surgery, like glaucoma surgery, people do have different preferences. This is my preference. I give intracameral dexamethasone at the time of surgery, similar volume that you would give to intracameral antibiotics. And the thing about that is, this is, as I said, most commonly combined with cataract surgery. These patients want to see well in day one. So giving a bit of intracameral DEXA really does quieten the eye down. I then do give 2 hourly of dexamethasone for 1 week, and then 4 times a day for 3 weeks. Again, a lot of concern about uveitis, fibrinous uveitis. I really have not seen this in my practice, having done hundreds of cases now, but I am quite aggressive with my steroids in that first week. If a patient is diabetic, I will give them a non-steroidal as well to reduce the risk of cystoid macular edema. Diamox. A lot of people in the UK do give Diamox for the first few days. Generally, for me, I don't. If the patient does have advanced glaucoma, I may consider it, but as a general rule, for the moderate population that I tend to use it on, I don't give Diamox routinely. But that probably is, again, different from different surgeons. So going on to a little bit about the data, there's a fair amount of data with ECP. There's a randomized controlled trial being completed in the UK, which obviously will against Phaco, which will give some great RCT data as well. But flicking through the data quite quickly, it's showing a good reduction in medication with this study here by Kandan et al. Looking at some of the older data going back from 2004, some of the pressure reductions are quite remarkable, really. And this is comparing ECP to armored valve. I think in those days, 2004, we had a lot less surgical options. I don't think I would say that ECP is something that you would compare to an armored valve patient, but it's just to give an idea of the pressure reductions. Philip Bloom, someone I know very well, has done some publications and a lot of work on ECP, and again has shown a pressure reduction down to about 16. What you may not have known about ECP, in plateau iris, so when you treat the ciliary processes, you do get a posterior rotation of the ciliary body. So we, as glaucoma specialists, have those plateau iris patients that have narrow angles, and we're removing the lens because primarily we want to try and open up the angles. When we do gonio at the post-op visit, we're like, the angle is still narrow because it's not a lens rise mechanism, it's a plateau configuration. And in these cases, I quite like to combine it with ECPL, endocyclophotoplasty. So as opposed to treating the whole ciliary process from tip to bottom, you just apply localized laser to the tip with the aim to rotate the ciliary processes back. And Benita has done some good work and published this. And yeah, I certainly see the difference in the gonio view post-operatively. ECP Plus, something that I have no personal experience with. It's done by retinal surgeons because it's through a full pars plana approach. But essentially, with ECP from the sulcus, you're treating just the front row of the but from the vitreous cavity, you can treat the whole processes. It is a much more invasive procedure, and the theoretical use also talks about uveal scleral blood flow and limiting blood flow to the ciliary body, but the side effect profile is also higher with cases of hypotony, CMO, choroidal detachment noted. So, you know, I'm not sure how much is being done worldwide, but again, this will be in the hands of the retinal surgeons, or at least the vitrectomy being performed by the retinal surgeon and the glaucoma surgeon coming in to do the ECP plus. Seeing the full picture, so certainly we wouldn't want to be playing American football like this. I sometimes think the England rugby team are playing rugby like this at the moment, despite their win yesterday. They're probably also doing this in training as well, and you certainly wouldn't want to consider this. And as surgeons, we really wouldn't want to be operating like this. So don't get me wrong, transscleral cyclodiode does have a place in clinical practice. But I think what's a really important take-home message is ECP and transscleral cyclodiode are not that same picture. Yes, they're both using diode laser, but in a very different approach. And I think this video quite clearly shows those pops that you hear when you do transscleral cyclophotocoagulation, it's a blind procedure. So you are treating what you think is the ciliary processes, but as you can see in the video here, the surrounding tissues are also being ablated and being damaged. Whereas with the ECP, you can see exactly what you're doing. So very important. Yes, they both use diode technology, but very different in terms of their visualization and the actual treatment zones that you're doing. This is quite appropriate after the Vienna ball. There may be a few people here with a hangover. Me, I've been good. But does mixing too many things create or detract from the outcome, which often for patients is actually seeing well? So obviously you have the iStent. This is the ICE2 procedure, iStent, Phaco and ECP. The iStent improves the trabecular mesh outflow. The ECP reduces the aqueous production and opens up the angles. Cataract surgery is also a glaucoma procedure. It lowers the IOP and opens up angles. And also, very rarely for a glaucoma surgery, it improves the vision and patients are happy. So, we're not used to having happy patients in glaucoma clinics before MIGS, but now we tend to have a lot more happy patients. So this is the procedure. Everyone is familiar with the iStent. I tend to perform the iStent at the beginning of the operation before the Phaco. Once the Phaco is removed, then you're just applying the ECP. And really, in terms of timing, this surgery, the iStent adds a couple of minutes to the surgery. The ECP, 5 minutes. It's not a long procedure. I do tell the patients that they are having 3 small procedures, but really, for their comfort, for the process, it's still very quick. The actual technique is similar that we talked about before, so I won't sort of go over that again. We published this back a few years ago in 2019 in the British Journal of Ophthalmology. What did we show? We looked at 74 patients, and this is the patient group. So yes, there were some with pre-perimetric glaucoma. These were patients that tended to have severe ocular surface issues, compliance issues, or a strong motivation to be medication-free. But the majority were disease. So, if they have mild disease, they probably would have had iStent by itself or ECP by itself. But when I combine iStent and ECP, it tends to be those with moderate glaucoma. What did we show? Well, here this was showing up to 12 months. What you're sort of seeing here is you're probably getting about an extra millimeter of mercury, a millimeter and a half extra reduction compared to iStent. So it does have an additive effect compared to just the 1 MIGS procedure by itself. When we look at the data up to 3 years, I think when I first started this, there were a lot of people that were skeptical, saying that by 24 months, by 36 months, you're going to have a regression to the mean and the pressures will come up back to the baseline. But what's encouraging is that a baseline of, just shy of 20 millimeters of mercury, even at 3 years, we are seeing pressures staying down around the 14 millimeter mercury mark, which is really what we are limited by to a certain extent, certainly by the iStent, by the episcleral venous floor effect. Encouragingly, the medication use has not gone up to despite the pressures staying well controlled, with a mean drop use of 1.3. 25% of patients were drop free, which for that cohort was a main motivating factor. But remember, for moderate disease, your main motivating factor is not to get these patients off their drop, it's to control their glaucoma. It's different if someone's got mild disease or pre-perimetric glaucoma. You really want to try and get that patient off medications. But for this cohort, it's really about trying to prevent their glaucoma from getting into the advanced stage. This is a really important slide, and I think I was really encouraged by this, because in the day-to-day clinic, when you're on that front line, you don't often see this, but I've seen that the number of filtering surgeries that I'm performing is going down over the last 5 years. And I think these sorts of, when you sort of crunch your data and you sort of say, actually, the mean deviation of this cohort was -8, and at 3 years, it's still -8. And none of those patients, 72 patients, and none of them have gone on to need a filtering surgery. So for me, that's hugely encouraging, that whilst we're bringing the pressures down, yes, whilst we're getting patients on less medications or medication-free, actually, we may be preventing these patients from needing to have a filtering surgery in their lifetime, which I think is, for me, a strong motivational consideration for this surgery. So that leads to a slight adjunct here about quality of life. So we've just published this paper a few months ago where we looked at the quality of life of patients having Phaco iStent with or without ECP. Again, the rationale behind this was in these post-op clinics, we were seeing patients that were happy. They were talking about their quality of life being improved. They were more confident, less anxious about their glaucoma, and their eyes were generally more comfortable being on less or no medication. So we did quite a deep dive into patient-reported outcome measures, looking at the EQ5D, the GQL15, the glaucoma symptom severity score, and the ocular surface disease index. From the ocular surface side of things, from the clinical side of things, we wanted to keep it very simple and very reproducible, and we looked at the tear film breakup time and the Oxford grading scale, things that can be done in any slit lamp in any part of the world. So what did it show? At the 4-month visit, and actually we've now got the 1-year data as well, that all these outcomes, the EQ5D, the glaucoma symptom severity scale, the GQL15 and the OSDI was statistically significantly improved, and probably more importantly, clinically significantly improved at 4 months, and this was maintained at 1 year as well. So the happy patients that I'm seeing in the clinics, you can sort of see actually a bit more of a detailed understanding of what parts of their quality of their life have improved by doing these quality of service outcomes. Yes, none of these patient-reported outcome measures are specific for MIGS. We do not have a MIGS specific patient-reported outcome measures, but these are the next best ones, similar to what was used in the EAGLE study, the LIGHT study. Here, looking at the ocular surface disease index in a bit more detail. Looking at the ocular surface disease in a bit more detail, not surprisingly, the patients that we were able to get off medications showed the biggest improvement in their ocular surface disease. The tear film breakup time and the Oxford grading scale also improved, and as you'd expect, the pressures had come down nicely to 14, and a drop in the medication burden, as you would expect with the surgery. So in summary, ICE2 continues to show promising results at 3 years. Visual fields are preserved at the 3-year mark. No further glaucoma surgery, including glaucoma filtering surgery, was required in this cohort of patients. ICE2 can improve the quality of life of patients. Happy patients make surgeons. ICE2 can also improve the ocular surface of our patients as well. But like all things, we need to continue to collect this data. So I was pleasantly surprised that the 1-year data has carried through to 3 years. And now obviously we need to check it again at 5 years. So see you in 2 years' time.